Welcome to Getting Wired, Decoding Neurointervention, the podcast that takes you inside the world of cutting-edge neurovascular care. Hosted by Dr. Rajeev Sivasankar, a highly experienced interventional neuroradiologist, this series is dedicated to unraveling the techniques, innovations, and real-world challenges of neurointervention. Each episode features in-depth discussions, expert insights, and case-based learning from some of the most experienced masters in the field. From advanced procedural techniques to the latest breakthroughs, this is the go-to resource for specialists looking to refine their skills and stay ahead in the ever-evolving landscape of neurovascular intervention. Get ready to learn, explore, and master the art of neurointervention. This is Getting Wired.
Hello, friends. In this episode of Getting Wired, it is a proud privilege of mine to welcome our guest for today, Professor Markus Holtmannspötter, who is the head of neurointervention and diagnostic neuroradiology at the Klinikum Nuremberg in Germany. So, hello and welcome, Markus.
Hello, Rajeev. Thanks for having me. I'm very proud that you invited me for that. Thank you.
So, Markus, I could think of no one better to dive deep into today's topic on Getting Wired. As we all know, Getting Wired's a podcast which deals with trying to get into the nuances of decoding neurointervention. And the topic of today is something that all of us neurointerventionists find ourselves at crossroads at times. That is wide-necked aneurysms at the bifurcations. And none better than our good friend Markus here to help channelize his thoughts and give us his opinions on how to deal with this complex, challenging disease. So, Markus, before we go into the technical aspects of the wide-neck bifurcation aneurysms, just tell us a bit about the hospital you work at and what kind of infrastructure you have there.
Okay. So, Nuremberg, second biggest city in Bavaria, in Germany. And I'm working in a big communal hospital with more than 2,000 beds. Probably not a big challenge for India. But it's also a private university, Paracelsus Medical University, and I'm working at the South Campus, and I am having a team of another 4 consultants with me. 3 further are fully educated in interventional neuroradiology, and the 4th is to be soon there. So we luckily will be a team of 5 covering intervention in elective and emergency cases in the very near future. And we play on 2 biplane labs, which are side by side. And I have a team of nurses and radiographers. And practically, we usually have 1 physician at the table, a nurse doing the sterile job on the table, assisting, and a technician who's the free hand to assist with everything else, doing documentation and fetching material. And we try to be 2 on the table most times. So as we're covering also diagnostic neuroradiology, so it's not possible all the time. But for educational purposes, also, so I think it's quite important that you're not alone on your cases, but you share your thoughts with one of your colleagues, experienced or less experienced. And so if the schedule allows, most of the time we're 2 physicians at the table.
So, Markus, in your practice, how do you define a wide neck bifurcation aneurysm? Do you go strictly by radiological criteria of the neck, or do you use your experience into deciding that your coils are going to stay in or your device is going to stay in and you won't need an adjunct device, or you can get by with balloons?
I think it's depending depends pretty much on size, acuteness, on the elective case. Of course, the first view goes to a shape and configuration of an aneurysm, and by experience, you already get an idea what's going to be easy or difficult. And I think the wider the neck gets, so everything beyond 4 millimeters, we face two main problems. The surface to the parent vessel gets bigger, so and this might be a problem with thrombus formation, maybe. And the other problem is that the prolapse of material inside of the aneurysm needs to be dealt with. And there's a third problem with it. The wider the neck, the more likely aneurysm recurrence is if you deal with normal strategies and not with stents. So that's my thinking. So small aneurysm with a wide neck are probably less of a problem, but bigger aneurysm beyond 1 centimeter, they're so much likely to have a recurrence in the future. So I think the strategy must also be targeted for what do I have to reach at the moment? Is it an acute case or an elective case? But also how to deal with the neck in the future. How can I get the sustainable results in some aneurysm? And this is with the wide neck aneurysm is more difficult to decide. And of course, there's an interdisciplinary view too. So the more difficult it might get for the endovascular treatment, a neurosurgical option might come into view. However, in our hospital, we have clear dominance of endovascular treatment. So this is sometimes quite different in different hospitals, depending on the skills of the neurosurgeon and, of course, of the skills of the neurointerventional team. So I think if you look at in the past, I've been a very stent-happy guy. And but this is also historical with the available of different devices. So there were coils and there were stents and balloons. I think in many parts of the world we underestimate the capability of balloons to get along with the remodeling balloons only, because we have those nice stents. So. And now we have intrasaccular devices which cover a part of the aneurysm, but only up to a certain size. So beyond 1 centimeter, intrasaccular device, usually definitely a standalone is not sufficient. And they also tend to have a high recurrence rate. So I think there's a cutoff at 1 centimeter diameter for those aneurysms, if they're not fusiform,
11 mm.
Where strategies tend to change. So beyond 1 centimeter.
So we'll come to the strategies part. Sorry for interrupting you, but I just wanted to get your initial thoughts on defining the wide neck. So like you said, using either a 4 millimeter or neck dome ratio 2:1, etc. And your experience to choose. Like you mentioned, a ruptured acute setting and elective unruptured wide neck bifurcation aneurysms. So if you say get a call in the middle of the night for a ruptured wide neck bifurcation aneurysm, does it matter to you? Or if it's an elective case, say an ACOM aneurysm, and it's say a centimeter in size, it's wide neck, will you go with the same strategy, acute or not acute? If you could web it, would you web it for in both settings, or would your strategy depend on the setting? If you could, would you prefer like stent and coils being more robust as an option in a elective case, and say web for a ruptured case?
I do have a predominance for intrasaccular web or contour. Artis doesn't supply so many sizes, unfortunately. So when we want to web it, I think there's in acute settings we love to put an intrasaccular device. It's also fast most of the time. So this is during the acute setting an additional advantage. Yeah, so patient is not so long flat on the back. The hypercoagulative state he's in is not being exposed to the catheters and the material in a long way. So there's also some advantage to the time. Still, we want to have most sustainable result, but I think when we look at our case numbers and if we assume even distributed number of aneurysms wide-necked in this size between acute and elective, you'll find more intrasaccular on the acute side. Yeah, so that's I think it's very reliable, and you avoid all the problems with possible dual antiplatelet medication.
Do you pre-medicate your patients in a ruptured setting if you're putting a web in, or a Artis or any other intrasaccular device?
I always work with heparinization during the procedure, also in ruptured. So I want to have an ACT, activated clotting time, of around 200 seconds. I'm not so much worried about kind of what is causing bleeding. And we pre-medicate only with antiplatelet, we only pre-medicate elective cases, but after placement of the web device, I also in rupture, I give aspirin IV. So we give them 500 milligrams of aspirin IV, because I think patient is on the aneurysm is occluded, the patient is still in a hypercoagulative state, and we've manipulated. So we always do minor scars at the endothelium. So, and from my early years in intervention, when we always waited like 15, 20 minutes after we finished the case, and it was not so rare that we found tiny thrombuses developing, not necessarily at the coil package or the implant, but at the side of the neck. So I think it's thrombus formation around the aneurysm during treatment is more based on minor scratches on the endothelium and creating a point where thrombus can develop. So I'm very happy with antiplatelet medication after occlusion of the aneurysm in ruptured cases. Yes, always.
And for how long do you continue antiplatelet medication?
We do it for 4 weeks. Yeah, so I think there's not. I think the key for me is probably in the early days. Yeah, so after intervention, around intervention, because it's usually not big scars on the endothelium. So if it's not a super wide area with contact to implant material, I think 4 weeks are completely enough. Yeah, so probably maybe even 1 week would be enough, but we don't have enough numbers. But for me, it's more crucial to have it close to the treatment to avoid peri-interventional microemboli or complications than for a long period of time. 4 weeks is our standard.
And now, we have so many options for wide-necked bifurcation aneurysms. We have right from, stent and coils, intrasaccular devices. We even have flow diverters at the bifurcations. And we have lots of combination techniques that we can use in these. So do you have a particular favorite? Like we all do have our particular favorites in our own hands and our own labs. So, what is your kind of algorithm to approach a wide neck bifurcation aneurysm? Let's take an unruptured setting to start with.
Yeah, so if we're talking about size up to 1 centimeters, we still look if there's a good option for intrasaccular. However, I have a close look at the neck, so you might have just a wide neck aneurysm, but many of those wide neck aneurysm also in that size, they include a bigger part of the bifurcation when the bifurcation looks dysplastic. Yeah, so that the neck takes like 180 degrees of the circumference of the vessel there. I personally think we need the stent because the disease goes inside the bifurcation more than if it's just a defined neck in the bifurcation. Then I think intrasaccular devices are a very good option for have a sustainable result. But in these dysplastic bifurcations, which are not so rare in wide neck aneurysm, scaffold by a stent is providing a more sustainable result, and that's especially in elective cases important to aim for, so that the patient is not exposed to unnecessary retreatments. Yeah, so I think that's adding a cumulative risk for the patient, and our aim is always to help the patient reduce his risk. We don't make the patient feel better by treating him as aneurysm. He's at least medically, he's not getting better. He's just getting his risk reduced. And if you have to do many treatments, then we didn't reduce the risk in the same way like if we have a sustainable result.
So, do you think that the results are equivalent between stent-assisted coiling and intrasaccular devices?
Yes.
In terms of robustness,
Yeah. So I think if you would, the robustness is decreasing with the comparability with increasing aneurysm size. I think if we would do a prospective trial and look for a wide neck aneurysm and take the aneurysm diameter also as a parameter, I'm sure we'll find a cutoff at somewhere where intrasaccular tend to have a high probability of recanalization, yeah, and where stenting has better results. I think this is a function of size and dysplasticity of the vessel. Yeah, so I'm sure, I'm not worried at all in aneurysms like 7 millimeters or below. Yeah, so it will be interesting to see the bigger aneurysm sizes going to, is it 1 centimeter, is it 9 millimeter? And are we better off with a remodeling technique or a combination like contour with coils or neck stent and coils? However, when there's this plastic aspect of the vessel, I think usually a stent is the crucial tool to provide stability to this plastic bifurcation for a stable result. So, but yeah, function of size and.
No, that's a good point that, if you have a wider neck or a more dysplastic neck, then an adjunct like a stent helps to endothelialize that and provides a more robust kind of solution. But while talking of recurrences in these aneurysms, after an intrasaccular device, we do see these little bit of filling in the corners, and it doesn't look too dangerous or anything, but till when do you follow these up, or in your experience have they increased to when do you decide that this needs to be retreated?
Okay, also if if there's an inflow into the device, so in the web device, I actually don't care too much. Yeah, so usually that disappears. Yeah. However, there's some. I remember two cases where there was still inflow into the device after more than 2 years. Yeah. So what's yeah. So it doesn't look like the result what we want to see, like Raymond and no neck and no dog ear. So there's not a clear definition to that. Yeah, okay, you can use the Boss scale now. But from the terms of what we wanted to achieve, so if there's no regrowth on the aneurysm, if the inflow is only into the intrasaccular device, what we notice in these long inflow cases is that the inflow itself gets less too. This was like in the Dynacity, you could see endothelium inside on the intrasaccular device. So the aim is to prevent the rupture of the aneurysm, and I'm sure this aim was completely achieved. Yeah? So if there's no regrowth at the neck, there's only inflow into the saccular device, so I don't see the danger of rupture. However, as we don't have a big number of experience with those cases, I think I would do still follow-ups by MRI scan, for example, every couple of years. Yeah, so why not? Also out of curiosity, if this status changes. Yeah, so but partial inflow into the device doesn't worry me at all if the rest is fine. Outside of the device is different. Yeah, so.
Right. So, coming to the more technical aspects of, say, stent-assisted coiling, do you have any, firstly, the location? Does it matter to you if it's an MCA bifurcation or an ACOM or a basilar or a carotid T? Does your choice or strategy depend on, is it more location specific?
Yes, I think so. Yes. I think we love to do more intrasaccular and ACOM. I think by nature, ACOM is more difficult to get a free projection of the neck. Yeah, so most of the time you have to find yourself in double obliques to get control of both pericallosals. So the projection in ACOM is normally much more difficult than in carotid T, in MCA, or basilar tip. Yeah, so usually that's easy to find good projections there. And intrasaccular device makes it quite easy to overcome this disadvantage. So you put in an intrasaccular, you do another 3D, you check is the intrasaccular close to the neck, is it covering the branch partially or not, and you can take it out. You can't do that with coils because you use more than one coil, yeah, right. So you have to make your decisions on the flow. And MCA, however, is a little bit more complex as if the left-sided, presumably the language area. So what branches are included? Yeah, so I don't have cross flow from one side, so there's some anatomical and neurofunctional ideas which are in the back of the head. They're not predominantly making decision. Usually I look at the aneurysm, get an idea, but in the risk assessment I also take into account what function lies behind and how big would be the risk there. So if it's very difficult to get there, or yeah, so if the angle is difficult, the more difficult the angle, if it's doable with an intrasaccular, nice, yeah. But beside that aspect, that usually there's more difficult to get a good projection in ACOM, I think I go
So for ACOMs, you like the intrasaccular because, like in the MCAs, like lots of times they are not straightforward. Like they say, the aneurysm should fit the web, for example, or the device. But lots of MC aneurysms are tilted, or they are on one side. Your device isn't exactly fitting right in the center of that. Uh, it's not those dream aneurysms we always want to have. And then you have trifurcation, and sometimes you have these branches coming out right from the neck, which need to be protected, for which probably only a stent or something could bridge two of the branches, or an intrasaccular would cover it. So like you're saying, probably ACOM, yes, an intrasaccular makes a lot of sense. And maybe for an MCA or something which is off axis, we may need to change a strategy to a stent, stent assisted coiling.
Yes, probably yes. Yeah. So in the end, the access and the geometry of the neck decides finally. But I think there's in my practice a predominance for this strategy. Yeah.
Mm-hmm. And do you use a lot of stent and intrasaccular together, or balloon and intrasaccular together, or you?
I think there's a certain percentage of that. Balloon is only when the angle is weird, if you don't have a good angle to enter the aneurysm, so that you use a balloon to force the angulation of the web into the right direction when deploying. Because what you can't really do is you deploy a web and then change the direction afterwards, how it's the axis of the web by a balloon. That usually won't work if it's properly sized. Yeah, so if it's undersized, it is too small anyway. Then you could do that, but and to have a good result, a proper sizing of the web is very important. So I'm tending more, if I'm between two sizes, I usually take the bigger size. So that results sometimes that I have some bulging into the parent vessel. And if it's a little bit too much, we decide that from a 3D run afterwards, then we put an additional stent across the neck to prevent this vessel. But I rather have some kind of protrusion, because that is also better for a sustainable result. So the web is rounded at the edges. So if I put a straight line as a base of the neck and I have the aneurysm, usually have some like super mini dog ears at the side. Yeah. So if you have some bulging into the parent vessel, you get the more circular connection to the endothelium at the neck. And I think this is crucial for a good permanent result, as well as the so-called oversizing or activation of the web device. So, and if you're too defensive for that, you will end up in less stents during the procedure. But then you have a tendency to be a little bit on the too small size, and then your recurrency risk starts. Yeah. So that's from the decision between two sizes. So if you're between two sizes, I always take the bigger one, also because of my psychology. So if I put the device in which looks nice, which is maybe a little bit undersized, the immediate result might still look very good. So you don't feel good as an interventionist, just, it looks good, but I take it out anyway. So if I take the bigger size, I might end up sometimes in the situation that it's maybe too much bulging, so I have to take it out. So, but then I'm forced to take it out, and I select the proper size. The other way around, too small device might still look good in the setting when you place it, and then you make compromises with the sizing, which are not good for the long-term result.
So, does it matter to you? Like, how do you size your intrasaccular device?
So it's
You
a bit,
follow
I
the
do
company
just,
sizing chart?
yeah, we have a sizing chart. The sizing chart over time with experience with the web improved a little bit. Before it was just kind of like historically
Hey.
1 millimeter more in width, one less in height, which didn't account for kind of like percentage. The same has a different effect in a 4 millimeter aneurysm than in a 9 millimeter aneurysm. And so it's more like a percentage now that with the diameter oversizing is. So the sizing chart is really helpful. And so when I do my standard measurements in width and neck width and aneurysm height, I've already sent the images to the simulation, and then I check what the simulation says. And simulation is giving also, not yet for the web, but for the RTs, the amount of compression, which can give you also an idea on long-term result. I don't know, there's a paper from Federico Cagnazzo, who works with Vincent Costalat, and I think they check retrospectively the simulation result on web and looked at the outcome. And so they actually could find values, cutoff values, which 90%, as far as I remember, predictability of a good long-term result. And I think that's pretty good.
Good.
So I think this is information which we can't know just by measuring, and we can't know by just simulation alone. I think this is in the future is data mining, which when we know we simulated 1,000 aneurysms and then we look at the results afterwards, we can get extra information which decisions prove to have the best long-term outcome. Yeah, so I think that's quite interesting too. So we do conservative.
It's very nice to hear. So, can you tell us a little more about your simulation software? Like, because we don't use it regularly out here in India.
Yeah, so the simulation software is it's not about access. It's only about the device to implant. Yeah, and there are several simulation softwares around, like Oxford Heartbeat, Ankyras, and Siemens Size. Yeah, so I have biggest experience with Siemens Size. I think they all do pretty good job doing stent simulation. Intrasaccular, I think so far is only available with Siemens Size and Oxford Heartbeat, the Precise software. But Siemens Size has the biggest portfolio, so which is kind of like mirroring what I have on the shelf. Because when I use simulation, I don't want to use a simulation which is only covering devices of one company or one device, because I want to have a tailored strategy for my aneurysms. And with the simulation, I can do now coil, stent, flow diverter, intrasaccular devices, and also combination of this. Yeah, so you would think, okay, why do I need simulation for coils? It's also that here simulation gives you some idea about the compression, not how the coil looks like in the aneurysm, because that's too random. Yeah, so but the aneurysm diameter and the size of the coil, and you get color coded. There's a strong Waller position, or it's a very loose Waller position. Yeah, so from red to blue, green is the best. Yeah, so or slightly getting to blue if you want to have more. And so you can challenge the software with some extremes also. Yes, I put in an intrasaccular. If I have a good Waller position, so especially around the neck, so I know this device has a very high likelihood to seal the aneurysm at the neck. So target achieved. And the same I can do with coils or also stents. So what I can't do simulate now is Y stenting. I would love to do that. Yeah. So, but I can do select the proper size of a stent and know exactly how long it will be in the given anatomy. So if I have a very complex aneurysm, I take my time, I go back from the table, I do the simulation, and I have my idea how I want to treat the aneurysm, but I give the other options a view and check, okay, could that work out as well? And so I also get myself a better understanding where simulation is helping me and where not. Yeah, so now it's a little bit investment of time, but not too much because we have a good workflow. So it's connected to our Angio suite, and it's just to press a button, the images are there, and then you do the simulation. And we can also send the pictures back from the simulation to the 3D, and I can put the simulated device as an overlay on my 3D roadmap if I want to. Yeah. So this
and you can choose which device you want to simulate. Like it could be an intrasaccular device, or it could be a flow diverter. You could choose from your simulation software what device you want to simulate. Is that right?
Yeah, that's right. And I don't have to go back all the way. So I simulate one, then I make a new simulation, and then I can compare the results afterwards. So I can say, okay, if I use an intrasaccular, that would look like this. A flow diverter in that side would cover the neck like that. And you can manipulate the stents with braided devices also along the neck. So you can add some more compression, so to simulate also some shouldering effect if you use a braided stent. Yeah, you use a laser cut.
Sounds interesting.
Yeah. So if you use Atlas, for example, so you have this open cell design, and you place it across the neck. Yeah. So then you can get an idea how much the struts of the open cell will point out. So in a dysplastic neck. Yeah. So sometimes you have maybe your parent vessel is like 2.5 millimeters and 2 millimeters distal in diameter. And it might still be a good idea to select the 4 millimeter Atlas because the neck is dysplastic. You go around the curve, then the struts are better remodeling the neck around the. So simulation can show you that or give you a good idea about that. And I think this is especially nice because we don't see the laser cut stents very good on the fluoroscopy. Yeah.
Yeah. Yes, that's true. Interesting. Very interesting. So coming to the stent constructs, do you like to Y stent or T stent? And if you do Y stent, how has been your evolution? Like earlier, we used to use like 2 atlases for Y stent, and then became 1 atlas and 1 braided, whether it's a Baby Leo or an Evo or whatever, or of course a T stent. With 2 braided stents. So any personal preferences and why do you think, for example, a Y stent would be superior or inferior to, say, a T stent?
Well, I think wide neck bifurcation aneurysm, reconstructing the neck works for me best with braided stents in Y configuration. Yeah, so. And in the last few years, I have, especially in the big aneurysm, a clear preference to do Y stenting with Elvis Evo and Junior. Yeah. So the Elvis Evo, I know there's Y stenting possible, but it's more difficult to get through the branches. And so far, my follow-up results with the Evo and Elvis Junior construct have been very stable, and so I'm quite happy with that. Sometimes we use Pegasus or Atlas when the bifurcation is less clear cut, or if I have a bigger problem with antiplatelet medication. So Atlas or Pegasus, which has similar like the Atlas, but has these this thrombogenity reducing hydrophil coating, allows me in difficult situations where I'm walking on knife's edge, maybe only use single antiplatelet medication, and at least I reduce the likelihood of thrombotic complication or stent occlusion because I have much less material. The flow is less disturbed. So if I'm coming from virchotrias, it's not only about platelet inhibition, it's also on flow and coagulative state if you have a hypercoagulative state. So in dire situation, ruptured case, big hemorrhage, need for a ventricular drainage, maybe over time again to switch the drainages or so, I prefer in those situations laser cut stent, Pegasus maybe with coating, so to stay with single antiplatelet, off-label of course, yeah. So, but I think that works pretty good. And if I have no restrictions, if I can use dual antiplatelet medication in a fine sense, then I prefer the braided stent because I see the braid, I know how the bifurcation looks like, and I have also a better scaffold for the vessel for endothelialization later on. And I think that also in very dysplastic wide neck bifurcation, the Y with the braided stent is the most sustainable solution. And you have kind of with this creating the Y, you have even a flow breaker kind of in the middle. Yeah, so it's potentially less inflow straight into the aneurysm. So creating some turbulence there, but diverting it right and left into the bifurcation. I think that's what I love.
We were talking about your constructs in Y stenting, and you preferred using Elvis Jr. in an Evo to make your Y construct. What is your personal preference in crossing? How can you take us through how you deploy your initial junior and you use a headway duo to cross do you jail the micro into the aneurysm sac and then you use a duo to cross the junior and then deploy the Evo? How do you make your Y construct?
Yeah, usually I jail one catheter into the aneurysm. Yeah. So I have less limitations than when I have to cross a Y-stented aneurysm to re-enter, which is possible, but sometimes cumbersome. So I jail one, which is most of the time a duo. I use usually a headway 17 for the deployment of the stents. So I go first. I prefer to go for the more difficult branch first. Deploy there the Elvis Jr. And then I take the headway 17 back and select then the second branch to deploy the Evo as the second stent. Sometimes the headway 17 in very difficult angulations is problematic because it's a little bit stiffer than the duo. However, the 17 provides a better stability to resheath the stent if you need replacement. So the tip of the duo might a little bit be too soft in some situation to safely resheath the stent. But that didn't happen yet to me. So if you have a long stent and duo, but you still need to keep in mind that you might damage the tip of the duo with a lot of resheathing of stents more than you would do in a headway 17 because the duo is not built for resheathing stents. So I think that's the key difference. Otherwise, the headway duo saved the situation for me more than once, because it follows easier a soft micro wire. Yeah, so sometimes I think, to my experience, is not an issue if you select in difficult anatomy, and I don't get around with my 14 wire. I size down to a 7 wire, a hybrid 07 with a J tip. So if I get there, then also looping with this very thin wire through the aneurysm and go to the distal branch with enough distal purchase with the 007 micro wire, the headway dual follows without an issue. So I think the headway dual is still a very important tool for me in difficult aneurysm. But the first choice, because it's better for manipulating the stent, is the headway 17. Yeah.
And what about your experience with T-stenting?
T-stenting, I think, is also a good option. So if you want to keep it simple, not too much material, especially if you get to smaller vessels, more distal, I think it's so in the pericallosal, for example, or kind of like when it's just minor vessels. Sometimes some people have big bifurcations, big strong circulus villi. Some seem to have in some areas very minor vessels. I think then you usually, if I decide for T-stenting, I'm in between. Usually, I think I try half T-stenting or extended half T-stenting first, and if it doesn't, if it's not sufficient, I can add a second leg and do it that way. And I think it's especially half T-stenting is for me a very good option. I do have one delayed complication with the T-stenting in the trifurcation. And you can call it bad luck, because it was a very good result finally, but and for 3 days there was nothing, and the patient did have a very good MR with no DVI lesions at all. But on day 5, the third branch, up to my opinion, it probably started in the third branch. The whole trifurcation was occluded. Yeah, so he suffered a big brain infarction from that, and so I asked myself, what's happened there? So I had one branch in the middle, which I placed Evo, which looked very nice, but then the neck of the aneurysm to the other branch was not covered enough. So I placed a second Evo in a T formation. It looked very good, yeah. So, and I've been proud of myself. But then I was confronted with the result. So the third branch looked nice too. I didn't see any delay, and there were no clinical symptoms at all. Yeah. So patient is on dual antiplatelet, but what my consideration were like with the Virchow triad again. So it's also flow. So if I have a T-stand in a bifurcation, I think it's no problem. So I have a T-stand and I have blood which crosses one braid, goes to the other stand and flows in the vessel. But with a T-stand in a trifurcation, you have at least to one branch. The blood goes in one stent, crosses a braid to the next stent, and through another braid, just a few millimeters later, in the third branch. So by creating 2 barriers for the blood in short distance, I think you don't cause necessarily a problem, but it's more dangerous because it's no clear standard. The patients are very individual, so even if they have a good platelet function, blood can thrombose. And we rely on that when we do flow diversion. Yeah? So we shut down the blood flow in the aneurysm, and we expect it to thrombose, even if we have dual antiplatelet medication. The same can happen in some situation, I think, if you cause too much turbulence with braid barriers. And so for a couple of days, it was okay with this patient. He claimed he's taking his medication, and we had measured the efficacy initially, and still he got the stent occlusion. Yeah, so it was a very bad result. So I will take that into account. So I won't do trifurcation T-stenting with narrow braids anymore. I think I had some consideration. So if I would have taken for the second stent, that would have been no technical issue. I could have taken an Atlas or a Pegasus, a more wider braid, or on Elvis Jr. So I would have caused less turbulence at the entry to the second stent and from the braid from that stent to the third branch. So I think that's what we have to keep in mind. And the same applies for me when I look at bifurcation flow diversion. Yeah, so obviously the result point out you can have with a very good likelihood, a very good outcome, but you cause remodeling and some vessels narrow down, and then they shut down. So for me personally, there's a little bit lack of predictability that the outcome will definitely be good. I think the chances are good. That's what the studies are showing. But from my experience, I try to avoid to cover relevant branches with too much braid if I don't have to.
Mm-hmm. So to put that in a line, you're not a great fan of flow diverting across the bifurcation?
No. So I do it when there's no other good option. Yeah. So, but I think there's still a risk that the flow decrease in the covered branch might cause a problem. So, and I don't want to gamble on that just on statistics.
Because we see a lot of flow diversion being done across the bifurcation from some parts of the world. Yeah. And the key to that, they say, is to keep the BP up for the first few days in the ICU, and then things are okay. And clinically, apparently, there is a little or no complication. Even if on a delayed stage, there is a knockoff of that division. It's supposed to collateralize well. But there are groups which are for flow diversion across the bifurcation. And of course, there are many who are not entirely convinced.
Yeah, and I appreciate what you say. Keep the blood pressure high initially. Yeah, so the Henkes group says, okay, we add anticoagulation like rivaroxaban or pixaban or so for a couple of weeks. And if I look at their publication on that, where they have like also a bigger number of flow diversion, I think they did this triple medication in more than 50% of the cases. So, so they have also worries about that and lifting the blood pressure, but you're adding some variables, some factors you have to control additionally. So I try to balance that. I'm not opposing that, but if I have a good other option to do it without increasing the treatment risk, so I would prefer that option instead. So I have to worry about less factors.
True. Okay. Now, just a quick question about: do you have any personal choices, or in your hands, do you think between, say, Webb and Artis contour or the next stent or other bridging devices? Do you think that there are certain advantages to some devices and some tips or some things to be kept in mind about certain devices? For example, there are some devices which are difficult to detach.
Yeah.
Some devices have problems with sizing. So, in your experience, what do you think, especially for those who beginning to use and understand intrasaccular devices in their countries? Like, not all regions have availability of all devices as of now. So, what would
No.
you recommend?
So I think they're all kind of not very complicated to use. Yeah. So issues with detachment, like tethering and non-detachment, are serious, I think, because you already had the risk to enter the aneurysm, and so if it doesn't work, that's a problem. Yeah. So I think most of these issues have been covered now. So I think the detachment, also the small webs have become very reliable. Most of the cases, but it's not that it never happens. Yeah. From regarding which device to choose, so if you have the freedom or the availability of all the devices, I think I look how the neck configuration is. What's the geometry of the neck, inflow, angulation of the branching vessels, because the devices share the characteristics that they have a tight woven mesh across the neck, but the configuration of the mesh is different. Yeah, so the contour gets more like a wine glass shaped form with a point towards the neck. The web is having a recessus, and the artise is almost flat when you push it in. Yeah, so additionally, the artise has a higher conformability regarding the shape. Yeah, so it adapts better to different aneurysm shapes. However, the artise is restricted in the sizes to few aneurysms. So because the sizing range of that device is not very big, and it's not yet been challenged for bigger sizes where it anyway might become more difficult, as we all know. The bigger the aneurysm.
We haven't had the artist launch in India as yet. So, can you tell us about what are the sizes available as of now?
I think the biggest artise is like 8.5 millimeters in diameter, and the smallest like 4, I think, or 5. Yeah. So, but regarding when you look at the sizing chart, it's not one-to-one from the web to the artise. So, I think with the 8.5 artise, I maximum can challenge a 7 millimeter aneurysm. So I stay in the sizing range, which is, for my opinion, less complicated than if I have to do a 8 or 9 millimeter aneurysm. This is a range, but what is really nice with the artise is it doesn't have the distal tip, which is sharp, like the web does. So it has a softer tip when in the beginning of the deployment. The web becomes fast, very soft. So I don't think it's a critical issue, but if you're not used to it yet, I think the artise is less traumatic in the tip by nature. And then the braid of the artise is nicely conformable. So if you have a more irregular shape of the aneurysm, and then you can, by a little bit pressure, squeeze the artise into the shape of the aneurysm, and which is helping you also. You do a proper oversizing like you're used to do from the web. And up to now, also simulation shows you a huge protrusion into the neck, which is not true in the end of it. So because of the better conformability of the artise device, you can, by just compressing the base of the device, you deploy the rest somehow in the aneurysm, and you can get a very nice remodeling of the neck. Yeah. So, but still I would see the configuration of the neck in three categories. The web has a recessus. So if I have an anatomy which favors that configuration and the web is fitting in that from the sizing, I would prefer that. So if I have more the bifurcation branches upwards, that is just by nature of looking at it looks like could be a good contour or neck stand case, yeah.
Right.
And the RTs, so if you is somewhere in between, but doesn't offer enough sizes, to my opinion. So it's a nice device, a very good device for a few aneurysm sizes, and I'm looking forward to see more of it. Yeah. So, but we will see.
Is it also is it delivered via an O2-1 microcatheter?
Yes, it's the O2-1 microcatheter.
And is that also deployed a bit outside and then pushed into the aneurysm? Technically?
Sorry? What do you mean?
The artist is also... No, I mean to say, like, when you deploy the artist, do you deploy it a little more proximal in the aneurysm sac and then push the whole device in so it fills into the aneurysm sac?
Yeah, so a little bit, this is that strategy where I start with the microcatheter is, for me, is more a function of how is the angulation of the aneurysm. So in the end, I want to have the neck at the base of the aneurysm, the base of the device at the neck, so not to have a neck remnant. Yeah, so that's, I think, what you describe. If you stay a little bit out of the aneurysm, so you push it just in the neck level, and then you have a perfect sealing. But I think I first want to have an opening of the device somewhere in the aneurysm. I prefer a deeper position inside the aneurysm, but before complete deployment, I take the slack a little bit more out of it, and then I pull it before it has a complete position. I put it more in the position, like you said, you would kind of like a little bit below the neck, and then push it inwards. Yeah.
Right. All right. And if you have now, just a few tips to offer to, say, fellows in training about, or more junior colleagues who are dealing with this complex wide-necked bifurcation aneurysms, what would be your advice to them as to how should they approach this wide-necked bifurcation aneurysm segment?
Okay, for wide-stand, so approach wide-neck bifurcation, I think my fellows learned all the intrasaccular first because that was close to dealing with thrombectomy. You have one device, you deploy it, and you can control the position after deployment, one device, and so you can take it out too. So at the beginning of the learning curve, that was, I think, very good for them. But of course, doesn't help you with the more complex situation when intrasaccular device is just not enough. And I think the biggest problem is not what to do, but how to get there. So what is the safest way for navigating the branches if you have to do a stenting? And I think where do you get the navigation skills for those wide necks, and what are the best tools to help you navigate through that? So I think ruptured cases and looping is still possible. So if it's a very wide neck aneurysm and the angulation is not favorable, I think then looping through the aneurysm is just often the best solution. But more ideal would be a direct selection of the branches. So how to select the branches, and I think this is very much a function of the wire. So you want to have the wire as soft as possible, but this is in this situation is not helping you, because with a soft wire you need a very distal position to provide enough stability for your microcatheter. So when I go for selecting a difficult angle, I definitely prefer more supportive wires like Acai, for example, so for Acai 14, because the tip of the wire you don't need to have it in that distal position, and it's easier to cover that branch. So that gap between neck and entering then the distal branch, and quite often I'm succeeding with that. And then the problem is with the proper projection. Yes? Sometimes you find yourself selecting the branch, and you have to have a good idea what's the best angulation. Sometimes just the change of the second plane that you get a better idea where does the tip of the wire need really to go. It looks nice on one plane, but the second plane is the key. And it's actually not a really new tool available, but it's not really used. So when I treat bifurcation aneurysm, I have the option in my angio suite that I use these polylines. It's like a 3D line. If I have a 3D, I can plot the line, so dot by dot, manually on the 3D image. And then I can have these lines and get an ideal projection to have the best view possible. And what is also possible, and you don't need an icono for that, you can use these polylines from the 3D as a live overlay on your fluoro image, on your roadmap. And not only once, it was so I was struggling to get the difficult branch, and I didn't understand where the wire was going, because on one plane it looked like just perfect. And then I could use these colored lines on the live view, and then I said, okay, in one projection it was just not good enough, and then I understood that much better. So I think taking the time and drawing the lines on the 3D is a very helpful tool to get the better projection. And
it's very interesting.
Yeah, and this and what is additionally a great thing I didn't have yet my hands on. In the past, I've worked with the Columbus wire. You heard that from Rapid Medical? But it was very difficult.
We don't have it, but yeah.
Yeah,
but I think the new Aristotle or something. I think it's called Aristotle.
Yeah, Aristotle
the directional wire.
Yeah, but you can't change the shape during navigation. Yeah, so but the Aristotle has a great torque and a great support. I think it's probably one of the best passive wires. Yeah, so what we have available. Yeah, and then the question is, so for most of the Y standings, I just need the 17 catheter. Yeah, so the next wire won't help so much with the small stents, but with the flow diverter stents, definitely. The drive wire, I think there's one or two wires coming out now. The drive wire is a 24 wire, and I tried it in the model. I think Canada and US, they have it and they love it. And so you select the curve, yeah, and then you can still torque it, and the curve is strong enough to keep that you can use it on your catheter. So you give your catheter the curve, yeah, and then you hook it in, then you just move the catheter over the tip of the wire. So I think we will see some progress that it will be easier for this difficult bifurcation. I'm not sure where the bendit is. Yeah, so the shapeable microcatheter, Alex Bernstein,
Microcatheter,
developed. So I played with that in the model, and I think that would also be a very cool tool. Yeah, so
right.
but it's not available for me. Yeah, so it's so far I have to go on with SI. Aristotle is very difficult to get in Europe. I think it's approved, but there's no normal distribution of the wire in Europe. But it's a very good one. And for now, for this difficult navigations, I stay with for direct navigation. I stay with the Asai and change for the Traxess if I need more torque. The SI is excellent for the distal support, but if you have many curves you pass before, the SI doesn't transmit the torque good enough anymore, I think. So then it's another problem. So you know where to go, but you can't get the torque in the right direction. And then again, I need the softer micro wire. And if direct selection is not possible, and I need to loop through the aneurysm, as we talked before, I sometimes size down and take a hybrid 07 for do the looping, and then I take the headway duo, which is so much softer.
Right.
That's a wrap on today's episode. If you enjoyed this conversation, don't forget to like, comment, and share. And for more insightful discussions, make sure to subscribe the channel.